Yes. Yay, yay. Now I got to get it back to where I was. Can I find it? No, I can't. Okay, PowerPoint. So the objectives for today, and this is interesting that you're going to get this in such a short period of time. Interpret lab data used to assess hematologic function. Interpret laboratory values that measure. I'm so sorry. We're here again. We're here again just trying to get the screen to show. There is no screen. Now let me watch you once again do this.
Okay, so I'm going to shut it down.
Okay, Kim.
Yeah.
Oh, you have no
Laptop.
computer. Thank you. McKenna, yes, would you read the objectives? Turn on your audio at the bottom and read the objectives while... Oh, we have to turn it off again. I totally forgot that.
I think that's the only way I've had success is to turn it off and turn it back on.
Okay.
We'll see. Okay.
Interpret laboratory data. How many yell loud enough for the class in here?
Oh, you're going to have to turn off your mic while she reads.
Okay, just a minute. Okay, but if it comes up...
There you go.
Okay,
So,
never mind. I can read.
So if you disable your mic, and she can read them. So
I've got my PowerPoint. Yeah.
There you go into presentation.
Yeah, I have that. Okay.
Yeah,
Okay,
shut that
thank you.
baby
I am
down.
so sorry.
No, you're
that I can
fine.
do this.
Yeah.
Okay, there we go. Sorry, let's all give Chantal a clap again. We're just so glad she's here. Okay, so here we go, and we're going to turn this until it's visible. Oh, somebody, is it visible on the computer? Everything, the slide?
Forgot my keys, sorry.
Oh.
You need to tip this down a little and slide it on back.
How's that? Down? Up?
Down a little. Yeah.
Okay. We try to do this every day, and I'm sorry. We lose 5 whole minutes of lecture, which is important. Okay. So you guys just read your own objectives. We can get through that. And we're going to skip these two because basically this is just a review of the blood clotting a cascade. You've learned that in pathophysiology and human anatomy. So it's just a review for you there. The thing that I want you to take away from this is that there are 13 factors required to clot blood. Isn't that amazing? I mean, it's a big deal. So anyway, you have to have them. And if you are missing one, especially 10 or 8, some of the more important factors, your blood's not going to clot. So you need to be aware of that. Okay, so is everybody hearing me on their computer? Is that loud enough for you, peeps? Maybe, I don't know. All right, so let's look.
It says it's not changing slides with you guys.
I have it. It's not? Okay. Well, then we will.
Well, that was 821. I can see it on the one screen, but not on the other.
On the one screen, but not on the
You can
other.
see it on your camera, but not
Yeah,
on
you can
the
see it on your
presentation.
camera, but not on the presentation.
All right. Wait a minute. I know it. Stay at home, people. Just stay at home. It's easier. I don't think this is going to work.
You don't think this is fun?
I don't know, but I'm so big, I want to show up tomorrow. Who's showing up tomorrow? Let's be honest.
I have to.
What's tomorrow?
Right.
Oh, farm?
There was like 6 people last minute.
Okay. Is it changing now?
I'll be ready.
Okay, I am going, because of the time that we're looking at here.
Yeah. Move forward a little bit.
Well, I'm hitting this right here. Are you seeing it now?
One more.
Are you seeing it full screen?
One more, yes. One more.
There we go.
There it is.
Okay. All right. As long as you're seeing it full screen. All right. So let's talk about this, and we're going to buzz through this, people. We have to. Okay. These are lab studies that usually are ordered. First of all, there's a bone marrow. Why do we take a bone marrow aspirate? Bone marrow produces the red blood cells. Well, produces white blood cells. It produces a lot of cells. And so we need to know if there's problems with the labs, what is causing that? What is happening with that? My daughter, when she was 12, was diagnosed with Wilson's disease, which is a liver disorder. She had like 13,000 platelets. And just let's look at this little slide here that the total platelets normal value is 150,000 to 415. She had 13. So it was like, okay, what are we going to do? Let's find out if the bone marrow is making those platelets or not. And in fact, it wasn't. And so there's that issue that we're looking for. Is the bone marrow doing what it's supposed to do if there's abnormal lab data there? A CBC includes total white blood cell counts, or total red blood cells, hemoglobin, hematocrit, and your total platelets. Now, notice here that you have normal values. Every facility is going to have their own range of values, but this is approximately a generalized, standardized range that all these values come in. You're going to need to know this. This is very important that a nurse, any great nurse, will get report in the morning, and then they'll go to their, after they get their 5 people that they've been assigned, they're going to go to the chart, they're going to pull up the MAR to see what meds have to be given immediately and what the meds are, make sure they know about them, and they'll pull up the labs, because the labs themselves could end up being a priority diagnosis for the nurse to deal with that day. Had a student that had a patient that died on her back in Oklahoma, and the potassium had been 2.9 for 3 days. Nobody did nothing about it. She ended up the patient had an arrhythmia and died. So you have to know these ranges. Now, luckily for you, the facilities will write a high and a low. And so they will identify abnormal values, but it is still your responsibility to check it. It used to be if there was a critical lab value, the lab would call the nurse and tell them. They don't do that anymore. Now they put a red flag. So you have to be constantly looking at the chart.
You still do that? Yeah, they still do that.
Oh, they do that. They quit doing that when I was at the bedside. And it was like, and I missed one day because nobody told me, and that's the way I was used to doing it. And they had changed policy. So it's good that if there's a critical lab value that the lab will notify the nurse, because you do have to deal with these things. So know these values. It's clear over here. Okay. All right. So when the physician orders a CBC with differential, they're going to break down the white blood cells and look and see exactly if there's a high white blood cell count. We want to know what is causing that infection. And so you'll notice there's neutrophils, eosinophils, basophils, monocytes, and lymphocytes. And you'll notice too what the percentages should be of the total white blood cell count. And you see those things there. But what I'm interested here, I'm not necessarily interested in the values or those ranges there. But with this breakdown of white blood cells, what is the cause? You'll notice that neutrophils increases with infection, eosinophils increases with allergic reactions, basophils increase with hyperthyroidism, and there are some bone marrow disorders. Monocytes are increased with chronic inflammatory disease processes, and lymphocytes are increased with viral infections. So when you get a CBC with differential and there's a high white blood cell count, the doctors, if they don't know what's causing the infection, They can look up this differential and determine, is this an allergic reaction or is this a viral? Do I need to start acyclovir? Do I need to start Rocephin? Because when it's extremely high, we want to deal with that as soon as possible. Basophils increase with hyperthyroidism. It's hyper, not hypo. Okay, so blood timing test, a bleeding time test. So this is necessary to find out how long it takes your blood to clot. So again, my daughter had a liver disorder. What is metabolized in the liver? K, vitamin K, which is necessary to clot blood. So they had to do a liver biopsy on her. And before they did, they wanted to find out how long it took her blood to clot, because how many platelets did you have? Like 13,000. So they did a bleeding time test on them. And what they do is they take this little circle of paper that looks like a coffee filter, and they have marks on it. And what they'll do is they'll make a little cut, and then every minute they will turn the wheel of this circular paper and stick it up to the cut that's bleeding and see if it's still absorbing blood. And so they want to find out how long it takes blood to clot. Now, a normal person with normal coagulation factors, it takes 1 to 9 minutes. She took 17 minutes. So what does that put her at risk for when you're doing a liver biopsy? Yeah, it was, yeah, right. So that's something for the nurse to watch afterward. Okay, so it evaluates, basically a bleeding time test evaluates platelet function. It's a very superficial incision. It's not like they go down deep. Prolonged bleeding time indicates that the patient has increased risk for bleeding, and it evaluates platelet function. I said all that already, so let's just keep going. Wish this building costs like $70 million. I can't make this happen. Okay. So we want to look at PTT values here. So PTT evaluates fibrinogen, and those are the factors. You do not need to associate that with which factors it's testing for. But if a person is on full coagulation therapy, like a heparin drip, then it takes, then you kind of multiply the time that it takes to coagulate by 1.5 to 2.5 of what a normal value is. And so you have to realize if they're taking this anticoagulant, then it's going to be, blood is going to be a little bit thinner than a normal person's is. And so it's going to be a little bit, take a little bit longer for the blood to clot. So you have to anticipate that. And then if there's inadequate quantities of any of the factors, especially with a person with hemophilia, then the PTT is going to be prolonged. So the higher number of the PTT is indicating that it takes a longer time for the blood to coagulate. Okay, so PT measures the clotting ability of certain factors. Again, I don't want you to spend time memorizing those. But again, you notice that it's over here, the PTT. So there's 3 letters in that lab value. So it takes 1.5 to 2.5 times the control value. PT takes 1.5 to 2 times the control value. So it's a little bit shorter. But anyway, and the INR is going to be for people that are on Coumadin or warfarin. It's more of an oral anticoagulant than an IV anticoagulant like heparin. All right, I threw this slide in here. There's no test question for it, but you need to be aware of it. And that is, I was doing clinicals one semester at Ogden Regional for the PN2s. I did P&2s once,
Oh.
way back when. But anyway, so one of the things my student had me come up, picture this if you dare. Maybe I shouldn't say what.
Do it.
But anyway, so the nurse was having trouble calculating how much she had she had a patient on heparin drip, and she was having to put it together with some infusing fluid already, some normal saline, and she was having trouble calculating what the rate was supposed to be. The nurse was. And so the pharmacist was sitting right there to make sure she would calculate it correctly. And so my student came up and said, I'm supposed to do that. So I had the student do it, then I did it. We got the same thing. I kind of looked at the pharmacist and said, and he said, yes, that's right. But the nurse just couldn't get it in her head, whatever it was. But he was talking to me about this anti-factor 10A, which is a new anticoagulant lab value that is taken, and they're starting to do that to replace PTT because apparently it's less expensive to do. So if you come up with a lab value for anti-factor 10A, it's XA, then recognize that it is an anticoagulant lab and it is there in lieu of the PTT. Okay. So why do we take some of these lab values? Because, or lab tests, because they're diagnostic. They lead us, remember, medicine is not an exact science. A person doesn't get a fever and you automatically say, oh, they've got COVID. They've got a fever.
Wow.
Like it is today. In the old days, a fever, could be multiple causes. So now we are investigators. We're doing our Sherlock Holmes. We're trying to determine what's causing the fever. Same thing holds true for a nurse. You see signs and symptoms. You're doing your assessment. You notice something that's abnormal. Now we got to find out why it's abnormal. And so this is the same thing that happens with lab tests, is that we get these lab tests, they're abnormal, we got to determine why. So when you're doing a complete blood cell count and you're getting your red blood cells, there's a lot of things that can cause them to have less than normal amounts of red blood cells. And if we go back to slide number 5, you're going to see that the normal range for red blood cells is 4.6 to 6.2 million per millimeter of blood. And so if it comes down significantly less than that, if you have maybe a 4, then we need to up our dietary intake of vitamin K and other things that contribute to the making of red blood cells, iron, and that type of thing. But if it's significantly low, we've got to determine why. So there's different kinds of anemia. Anemia is a reduction in either the number of red blood cells or the amount of hemoglobin or the hematocrit percentage.
Say that again.
Yes, I will. Anemia is a reduction in either the number of red blood cells or the amount of hemoglobin or the hematocrit, which is the percentage of red blood cells per deciliter of blood. It is a clinical sign, but it is not considered a disorder. So it's not a disease. It is just an abnormal assessment finding from lab values. And it can be the result of many health problems. So if the lab value comes back that the person's anemic, we got to determine why. And there can be many contributing factors to that. So hyperproliferative anemia is the indirect or the underproduction of red blood cells by the bone marrow. But it's usually because of insignificant dietary intake. So there's different types because it's associated with dietary intake, and it's not something like leukemia where the body itself is failing to produce this. The body is failing to do this because of insufficient elements that are required to make red blood cells. But there's different types of that. So with hyperproliferative anemia, there are different kinds of anemia. First of all, there's aplastic anemia. There you go. And then you have anemia in renal disease. Why do we have that with renal disease? What do the kidneys have to do with red blood cells? Erythropoietin.
Hey,
Everybody take a drink. Let's say it 3 times really fast all together. Okay, so let's see. So anemia, we talked about that. Iron deficiency anemia, where you're not getting enough iron intake, vitamin B12 deficiency, folic acid deficiency.
Deficiency. I like how the C was.
Deficiency.
I like this one.
Aplastic anemia occurs because the bone marrow's inability to make red blood cells. And leukopenia is a failure of the bone marrow to make, to produce white blood cells. All right, let's keep going.
Okay.
All right, so let's talk about this hemolytic anemia first. And this is really something that you're going to see very often, maybe not so much here in Utah. Why? Because we don't have a very diverse population here. May I just say this out frankly? Yeah, I'll just say it. First thing I asked when I came in here, and I said, where are all the Black people? Because really, you laugh about that, but it's amazing. Once you get outside of Utah, you're going to see a much more diverse population. And so sickle cell anemia was something that I frequently had at the bedside, but half my students, at least half, sometimes 3/4 of my students were African American. And so it's something that when you get into more diverse populations, you're going to see more often. So you need to know these things. So sickle cell anemia. This is can be one of the causes for hemolytic, and also when you have acquired hemolytic syndrome or anemia that Chantel's going to talk about later. But hemolytic anemia is anemia that is caused because you have this destruction or this lysis of red blood cells earlier than they're supposed to be. How long does a red blood cell live? 120 days. And so, that's the lifespan of a red blood cell. But for some reason, there's something in the body causing those red blood cells to lyse early. So that is basically a hemolytic anemia. Another cause of anemia is significant blood loss, where you have hypovolemia, which is going to, of course, cause there not to be sufficient red blood cells to do their job. So let's talk about aplastic anemia for just a minute. That's a failure of the bone marrow. So we got to assess why is the bone marrow failing, and we want to look at the macrocytic anemia. We're going to talk about the macrocytic and microcytic and all these different kinds of anemias in just a minute, because it's the quality, the shape of the red blood cell. But leukopenia can also is caused by failure of the bone marrow to produce enough of everything, and thrombocytopenia is decreased production of platelets. So the causes can be exposure to toxic agents and drugs. Radiation is going to do this a lot. Chemotherapy is going to do this. I just said ionizing radiation. There you go. Infection, 50% of it is that there's no known cause. It's not really evident when you're first starting to investigate what the cause is. And it could be the result of a viral infection. But this is what happens when you draw your red blood cells. And as part of this complete red blood cell count, they're going to look at the quality or the characteristics of that red blood cell or the red blood cells that are being produced. So macrocytic, and let me, you have your definitions on this slide, but in the next slide, you're going to see a visual representation of these different, yes, sir. We're not moving forward, are we? Yeah, well.
It's moving forward online. It's just
But
this one that's
but Mark needs to have it here.
yeah.
It's here, just a minute.
You're just talking about that.
How would you want to know that?
We'll skip 15. Go to
Sometimes I want to learn.
There we go. All right, so there's a picture. Look at this and listen. So here we go. Macrocytic is that they are abnormally large. Now you're going to see this with MCV. You know, have you ever looked on a complete metabolic count and a complete blood cell count? These labs come in and they've got all these little initials and you have no idea what they mean or what they're used for. So MCV indicates it's an abnormally large red blood cell, and macrocytic. So large blood cells are usually the result of a vitamin B12 deficiency or a folic acid deficiency. Abnormally small red blood cells are usually caused by an iron deficiency. Now, if you have an MCHC, which is your mean corpuscular hemoglobin concentration, of course, they're going to put initials with that. MCHC, you see that on your little lab value there. You have hypochromic red blood cell that has a deficiency of hemoglobin, which is going to cause what? Exactly, oxygen carrying capacity. So what do you anticipate their stats are going to be? So this is usually the cause of iron deficiency anemia as well. And with normocytic MCHC, it's going to indicate that there's normal hemoglobin capacity there. But again, the red blood cell lyses early. So there's a picture, enjoy. Okay, I'm going to have to go back and forth between these slides. Between people there. Okay. Okay, so, all right, we talked about chronic renal failure, that erythropoietin is the reason why, which is the hormone that stimulates red blood cell count or red blood cell production. But also in dialysis. Now you can imagine, this makes perfect sense, that you have all this blood going through this machine and is being filtered. It's going through this being forced to go through these filters, and then comes back and is reinserted. You're going to lose some red blood cells there. So dialysis is also that. So that is one of the reasons why somebody that is in chronic renal failure usually is anemic. I am amazed by the whole thing. Who came up with those filters? Who thought of that? I don't know that. I don't know. Yeah, very rich now. Okay, so let me go here. Let me go back down here, here. Oh. Let me click here. All right. So iron deficiency anemia is very common in children and adolescents and pregnant women, and in undeveloped countries and in some elderly. Now, the thing about it is that dietary iron is insufficient in children. Oh, I just read that. and we talked about that it's found in microcytic and macrocytic anemia, and of course in blood loss. Yes. Oh my gosh, this is the story of my life. So where are we at here?
Yeah.
It is fine online. Well, I know, but here people got up and got dressed this morning. So let me get this.
How do you believe too much? I showered last night. Woke up and put on a sweatshirt.
I don't even know where that's coming from, to be frank with you.
So there's my effort.
Oh.
So those the same leggings you slept in? I'm just kidding.
No, actually, I did change my sweater
Okay.
because these ones are warmer and it's really hot in my house.
There we go.
I wore my slightly less comfortable sweats.
I know that like as we get closer to the end of the semester, my motivation to get ready is gonna start deteriorating. So enjoy this while you can, everybody, because eventually it's gonna be.
Okay, we're back. All right. There's another cause of red blood cells, and I would, if I were you, I'd start making a list on my fingers what kinds of anemia are going to be because of iron deficiency, what kind are going to be is there because of B12 deficiency, vitamin B12, or folic acid deficiency. You need to be able to know what kind of anemias that we're dealing here. So with B12, poor vitamin B12 intake is often found in people that are vegetarian or have dairy-free diets. It's essential for the manufacture of DNA, and the red blood cells help contribute. Well, the B12 also contributes to the myelin that covers nerves. It's required for a highly specific protein called intrinsic factor, which is part of part of clotting. Thank you. So pernicious anemia have low gastric acid levels and have many antibodies to the intrinsic factor. So both abnormalities are associated with poor absorption of B12 or vitamin B12, which there's poor absorption for it. So the B12 that you do take in is not absorbed into the system to help make the red blood cells. So if you have that, if B12 in fact contributes to the myelin that covers nerves, do you think they're going to have paresthesia in the extremities? Yeah, you are. Yes, you are. So got to have that stuff. All right. Here we go again. Let's change all our little screens here. Okay, so folic acid deficiency, alcoholics really do increase the need for folic acid, and so you are going to find that Alcoholics oftentimes are anemic. We just talked about malabsorption diseases that you have with your with intestinal problems like ulcerative colitis, Crohn's disease, those type of things. Folic acid deficiency, you want to increase your folic acid, so you can do that with green leafy vegetables, liver, citrus fruits, dried beans, and nuts. So if you have a person that has anemia, you want to encourage that type of intake. So we talked about all the different kinds of anemia. The thing about it is that when a person has anemia, it doesn't matter what kind, whether it's folic acid deficiency, whether it's iron intake deficiency, doesn't matter. Hemolytic anemia, it doesn't matter. All the signs and symptoms for anemia are going to be the same, and it's going to be fatigue. They are going to be exhausted. And when you have severe anemia, it's just debilitating. Yes.
I have two questions. So going back to the vitamin B12 deficiency,
Yes.
It says under the symptoms that they'll have like a loss of position sense.
Because of the myelin on the nerves.
Oh, okay. Never mind.
Yeah.
Okay. So, and then my second question, with alcoholics, it says that they have an increased need for folic acid. Why do they have an increased need for folic acid?
I have no idea.
Okay.
I be frank with you, I really don't know.
Okay.
But I just know that alcoholics, I honestly don't know the pathophysiological process to it.
What?
No.
Oh, sorry.
Oh, I don't know what the process is to it. I just know that oftentimes they're anemic because of that, because of that specific thing. Sorry, I admit it. I don't know. Okay, physical assessment of anemia. Let's go into that. So I talked to you about extreme fatigue, dizziness, lightheadedness. That's a real word. Lightheadedness. I know, but doesn't that sound odd? You're just dizzy, okay? Lightheaded. But lightheadedness, I don't know. Anyway, so why do you think that is? They're anemic. They're red blood cells.
Yeah, less blood, less oxygen.
Exactly. Less oxygen. Orthostatic hypotension, syncope, evidence of bleeding, frank blood, and occult blood. So we have to check. For people that are anemic, we have to, one of the things that they're going to check is occult blood. We're going to find out, they're going to do a guaiac on them. They're going to find out, are they bleeding internally? Because one of the reasons why a person is anemic, and what is the most common in the United States, in fact, is significant blood loss, hypovolemia. So if they're anemic and you take a look at them and you see, well, they're generally, nourished and, they've got a little bit of fat on them. We just, let's find out if they're bleeding internally. It's hypovolemia, which is causing the anemia in the United States. Yes. McKenna.
What is frank blood?
Frank is red blood. It's like you open a vein and it comes out.
McKenna, it's like
As opposed to
when
green
they say,
blood.
Quite frankly, like it's just out there in the open.
It's just, there's no, if you visually see bright red blood in the toilet, that's frank blood.
Frank is very
I cut
obvious.
myself shaving today. There was frank blood flowing down the drain in the shower.
Frank cut himself shaving.
There you go. Okay, so the thing about it is you look at all of this stuff, yes.
Be more fully because they basically just eat out.
Oh, well, there you go.
They don't eat enough of it. They eat like crabs and they have intestinal malabsorption.
And then they just pee it out. Well, there you go. Thank you for that. Now we all know, because I learned something new. Yeah. Okay, so we look at this, these signs and symptoms of it, and it all is perfectly clear. The red blood cells carry the hemoglobin, which carries the oxygen, and if you don't have any oxygen in your brain, you're going to be dizzy, lightheaded, have tendency to faint when there's an immediate change in position. All right, sickle cell anemia, I'm going to go through fairly quickly with sickle cell anemia. What is happening, and this is what is so interesting about sickle cell, and I've had several students, African-American students that have had it as well, and it wreaks havoc with nursing school. Because here it is, and I don't get it. You're going to have to look up the pathophysiology to it as well, because if the body, a person with sickle cell, senses a change in oxygen, that's all it takes, senses a change in oxygen levels, the red blood cells, instead of being round, turn to a sickle shape, which wreaks havoc when they're traveling. Doesn't matter when they're going down a straight artery, but if they take a left or a right going down an arteriole, then all of a sudden it can get hooked on that little change of shape and start to clot off. They build on each other, they adhere to each other, and they start to clot off that arteriole. And so they are in extreme pain. They have extreme pain, and they are so stiff in their joints they can hardly move. It's awful to see them, and they recognize it. This is something that happens, is lifelong. They have to often be hospitalized. In fact, the pain is the reason why they go to the emergency room. But when you're get hospitalized for it, what they're going to do, they have a little machine that pulls blood out and switches it out, and they infuse the amount in that they pull out, and they're switching out. They're basically transfusing the whole volume of blood to get round red blood cells back into the body. And what is it? What causes it? Stress causes it. So welcome to nursing school. But changes in levels of oxygen in the body senses it. Who knows what the trigger for it is? We don't know, but we do know that it changes, and when they have an exacerbation of sickle cell anemia, they are going to be in pain, and they are going to be it's going to be hurt like the devil to walk, especially in their joints. Yes.
Steph was just saying her 11-year-old patient at Primary Children's had sickle cell, and
it was horrific. It is. It's the saddest thing, especially a little 4-year-old. How do you think that they don't know what's going on? The adults that I've had as students are pretty well, know what's going on. They've lived it long enough. They know what they have to do. They know what they have to do. And, sometimes it requires them to have to repeat the semester because they've had to miss so much clinical or classwork. So it's not a fun disease at all. It results in acute pain. The clinical management of it is that we want to focus immediately on the pain. We want to administer appropriate and effective analgesia, and then we have to, again, give them non-pharmacological pain management between meds, so to speak. Okay, make sure you do your Coldera with it. The complications of sickle cell is that you have chronic pain. We've talked about that. You're going to see on the slide that you need to focus on a rapid, comprehensive pain assessment, and we just talked about administering appropriate analgesia. Now, here's the last little slide we have, and I'm sorry, we're just not moving with. Here we go. Sickle cell. Here we go. Oh, let me go back up for just a minute. Avascular. Acute. Here we go back up. Where are you? This is where we're going to be at. Okay, I do it here. Now let's go back over to, I am so sorry for this, people. We are going to get this fixed by the time you graduate from Weavers.
From Weaver.
It's a bad
I love to
joke.
know that expectation of me.
Okay, so you imagine here that your person is going through here and has got these sickle cells that are starting to work their way through the arterial vascular system here, and they start to occlude these little arterioles. When you think of potential complications, what is that going to end up with? And you can see clearly that avascular necrosis will result from temporary or permanent loss of blood supply to the bone or the hip or the shoulder joints, because that's where your little vessels are so small, and that's where it's going to clot up first. And the clinical management of that is physical therapy and exercises. And in severe cases, they're going to do a hip replacement. Complications are also going to talk about priapism. Do you know what that is? I asked my...
It says it up there. Slide.
Read the slide out loud, Kim, for us.
An undesired, persistent, often painful erection that can lead to erectile dysfunction.
And she said it without hesitation. I'm impressed. Okay, so the thing about this is, and I asked my friend Shauna, who used to teach pharm, she doesn't teach it anymore, but I asked her, I said, have you ever used that word? Of course, my background's in pediatrics, so we didn't have this word that we used a lot. She said, well, yeah. I said, okay, what is it? And she told me what it was, and I said, oh. I said, have you ever seen it? She said, yes, I have. So I guess it's a real syndrome that is not common, but she has seen in 25 years of nursing, so she's seen it.
Is it like the wonders?
Well, it is?
Yeah.
Oh, I didn't know that. See, I didn't know that.
One of the signs you look for is like EMS, you look for that.
Mm-hmm.
For spine injury.
I didn't know that.
Quick sleep.
Really? I did not know
Is it
that.
like the blood goes down, but it won't come back up, and so it stays erect?
Oh, see, I'm learning from the students. Who are the teachers? The students. Okay, let's keep going. Acute chest syndrome. This is pleuritic chest pain, fever, crackles, auscultation, pulmonary infiltrates on chest x-ray. And this is, what we do for this is, again, analgesia sufficient to reduce the respiratory hypoventilation. Because are you going to take full deep breaths when your chest hurts?
No.
No, you don't. So you're going to have to, again, do your pulmonary toileting that we talk about, where they do incentive spirometry, or you take deep breaths where you totally hyperventilate or hyperinflate the lungs, and then fluid management to keep make sure that the person doesn't become hypovolemic. And stroke is another cause of that, and you can read that. So when a person has sickle cell, you want to prioritize the activity with rest, maintain adequate nutrition, monitor and manage complications. Make sure that when you are preparing for the exam, that you look at different foods that have appropriate intake of iron, or not intake, but appropriate amounts of iron, or good sources of iron, good sources of folic acid. And that being said, goodbye. We are 10 minutes over. In 5 or 6 minutes, Chantel's going to be in here. Woo! Now, while we're closing, and this is officially closed, the lecture, then I will have a review tomorrow that I will put on a conference. I will probably do that while you are in pharm class, so don't join my class. I'll kick you out. But you can view it afterwards, and the review will be for the exam, will be for my portion of the exam, which will be 50 questions. Okay? Yes.
nursing care for anemia is food high in iron, and then you said something else.
Folic acid.
Folic acid.
Yes. B12, vitamin B12. Got to have that in there too. Yes, we do. All right, people. Goodbye. Take a break. Go pee. Do something.
Oh, wait.
Any questions from people out there in cyber land?
Oh, Maddie.
I'm just gonna draw
And Chelsea.
Okay, I apologize to you guys for the PowerPoint situation. I will have classes on it this week, so hopefully next week will be better.
I just want to double check, you said that